Thank you very much. Appreciate both of these presentations. And I'm really glad we could accommodate to you today instead, as opposed to not hearing you at all. So as your slides sort of flashed by there, you had a list of research priorities. I assume they were all included on the slides.
They are. Actually, so all the research priorities are on the slides, and they're also in the paper, which is publicly available. So it's not behind a paywall.
I'm really looking forward to making sure we get that list into the report of this proceeding. So that's why I'm asking that. So that's good. That's great. So thinking a little bit about the research you're both doing. Dr. Betz, you laid out a very nice logic for looking at the numbers and then tailoring it to a location, Colorado, and then making judgments about where the interventions should be in order to have an impact, some of which were directly related to guns and some of which were related to the broader issue of suicide. It seems to me that's a very important illustration of the thought process we need to go through over and over again about a number of interventions. But then you went through the whole presentation, and I didn't hear how it works. How effective it was.
That's because we're testing it right now.
Right.
So I can't look at the data yet, but. If may I?
Sure.
Yes, so I think this is going back to my school public health days, there are a lot of different ways to look at burden. So absolute numbers are one way, and if you look at absolute burden in that sense in the U.S., suicide is the lead for firearm deaths. If you look at rates, though, we know that it's young African-American men in, especially urban areas dying by interpersonal violence. And so there's no one right way to do it. And I think this is where it gets to sort of what is affecting a healthcare system, a community. What Chris is dealing with in rural Vermont is different than what I deal with in suburban Denver. But I think it's really important that when we're designing these overall processes, at least remember the big picture, because I think too often certain segments get ignored. And I think it's often unintentional, but I think it's still very problematic. In suicide in particular, there's still a lot of stigma in talking about it and a lot of misunderstandings about whether it's preventable or not, and I think we really need to and I think when we leave it out of the gun violence picture, it perpetuates some of that as well.
And I think there's an analogy to the issue of hypertension in diabetes control. About 1999, I remember, some of our researchers came to some of us and said, the most lethal factor for people with diabetes is not the control of blood sugar, but rather the control of blood pressure. And that's when some of the standards migrated to including blood pressure as a factor in a diabetic set. So it's stuff like that that's really important, and that's why I liked your thinking about how the gun violence issue sits in a larger issue, and then really, from a practical sense, trying to figure out how those factors ought to be addressed in your research.
Thank you. The other, I guess, related thing I would say, one of the slides I left out today looks at rates of death among youth by firearm violence. And so I'm a parent, I have kids. I am horrified by the fact that I spend even a second worrying about their safety at school. Like that we've gotten to that point in this society is horrific. But I also know the numbers, and they are far more likely to die by suicide than in a school shooting. But I don't talk about that enough, and I think that's one of those things that we need to think about. How can we be educating parents on this, especially if you're in communities where a lot of parents do own firearms? How do we change the message so that guns stay locked up until the kids leave the house, not when they're 13 and have taken a safety course? Like, how do we help our patients and our communities understand those relative risks? Because I think we have the responsibility for looking at the numbers and making our own priorities within that, but then also sharing those relative risks with our patients.
And I think the important thing there, Emmy, which I think you've done so amazingly well, is to make sure, I'm a fan, but no. But I think is to make sure that the voices of the people who we're actually trying to get to are heard. That I think, again, that it's easy for us to kind of to say, well, this is clearly what should happen. But I was talking to someone the other day, and we were saying that we were kind of going back and forth about gun violence prevention, and we're like, it would be like trying to stop motorcycle crashes by talking to a bunch of bicyclists, right? That's not going to work. And so if we talk to a bunch of non-gun owners about how we're going to stop gun violence, particularly gun suicide, that's not the solution, right?
As long as we're giving out compliments. The other thing I liked about the story was the use of the Ottawa decision framework for preferences. We've actually used it in a number of other ways that help us tailor and target things in a more appropriate kind of way. So there was a number of ways in which that appealed to me, and it looked like a really practical sort of thing that might have impact.
It's so cool.
So let's assume for a moment, for both of you, that that framework has impact, and you get it published and win some sort of prize for it, and which you ought to. Then the issue becomes for operating health systems, how do you deploy it? How do you scale it? How do you move from the research setting to a more operational setting? And I know at the University of Colorado system, it covers all of the Front Range. Actually, I'm a patient of it, but not in the Denver setting, and so forth. So I'm wondering if both of you could kind of, as from your research perspective, think about what you will need to be doing or how you will need to be handing off the kind of design issues to those that would then scale this successful, we'll assume it's successful, intervention and deploy it, say, across every emergency department in the Front Range or every emergency in the Northeast.
So I think, so there's obviously a whole science behind dissemination and implementation research, and I know that Renad Betz is going to be here tomorrow. She's another friend and collaborator, and we'll be talking a little about that. So I will defer to a certain extent to the D&I folks in the audience. But that said, I think that there's a few things. So one is that having something that does not require more of our workforce is critical, and that's where I think the use of technology, whether it's her app or my texting or Pat's app, is critical, because it allows our providers to keep doing what their focus is, which is saving lives or preventing disease, while not asking them to add on yet another burden to their plate. So the first thing I think is making it easy. Then the second thing is having the support of the folks at the top, right? Like the culture starts at the top, and you certainly need people leading from the middle, and you need to have change agents within the hospital. But if the C-suite is not encouraging it to happen, it won't. And then there's that process of getting people on board, whether you call it academic detailing or kind of providing quality feedback of making sure that people see the value to using whatever technology it is. So it's a series of there's a series of steps that are needed. But at the end of the day, you need the evidence to show that it works, and then B, the support of the folks at the top, and then C, to make it really, really easy for our providers. And I think that's why many of us who work in emergency medicine have tried to say, well, how can we get around asking a provider to do more screening and intervention? Because, and David, I actually don't know if there's a paper that I quote all the time where if a primary care provider did all the screening that they were supposed to, that it would be like 8 hours a day or something like that. And it's just as much so for emergency medicine, right? But we only have 5 minutes with a patient instead of 15. You know, primary care providers have this luxury of time for us. So we have to find these like out of the box solutions, right? So to me, that's the answer.
So there, David.
Yeah, and I think that includes looking, and this is not the area that I work in, so this is again where you need to bring in the experts, but the different kinds of patient-facing options. So, you know, we now have them like My Health Connect, and it's funny because patients will actually now like flag me down and be like, I saw my labs came back 20 minutes ago, how come you haven't come and told me what they were? Which is a whole new experience, but and it's wonderful when you get people who are that actually engaged. Yeah. And so thinking about how do you embed things appropriately or build them or push them out to patients who are already interfacing with their healthcare system that way. For people who aren't, how do you have tablets or other devices within the ED and that can be cleaned and not stolen and all of those kind of logistical issues. And then how does it interface with the medical record or not? So our department is doing some pretty interesting work with different, venture kind of tech firms trying to build things into Epic, and thinking about what needs to live in the medical record versus not. And I think these are all like fascinating questions that I won't be the one to answer because that's not the space I work in. But with everything, I mean everything we are designing, I would say, has that in the back of my mind, because we really have to, again, it goes back to knowing the community of both the patients and the providers you're working with to make it actually something that people want to use and will use.
I take my own tablet with me and access the app.
Good for you.
Good for you.
But anyway, what about the factors? So you're really saying that there's another set of expertise that will take what you're doing and deploy it. Is that
Maybe we'll have a K-24 to help us learn it, but otherwise we'll be depending on other people.
So my question is, should you or have you really designed your research or that agenda being informed by what the anticipated need will be to take it and convert it and implement it and scale it?
I mean, I think that we have, but we certainly have people on our team who are experts in this realm. I mean, we chose to make ours as a website as opposed to a freestanding app because we felt like lots of people don't want to download things and it didn't need to be a whole app. We also chose not to design something that's supposed to be embedded in Epic because it is a patient-facing tool, not a provider-facing tool. So the question of how you then allow providers to sort of see it or note that the person did it, that's a good question. But I think we were also trying to design something that wouldn't be only for emergency departments. But for example, I would love it if at some point, if it works, it becomes embedded in patient-facing, sort of public-facing sites in the correct context. So for example, if there's safety planning or other things. So in that sense, having it in just a web-based format made the most sense for sort of portability, as opposed to like a beautiful paper booklet that like nobody uses paper in the ER anymore. So in that sense, I would say yes. This question of how you interface with providers is a good question. But at the end of the day, I was trying to make something for patients more than the providers. Yeah.
And I would say that to kind of our consensus research agenda from ASAP or from the work that we're doing with a firm, that it all has started with kind of that end user in mind, whether it be the provider or the patient. That I love doing research. I'm like, I love doing research for the sake of doing research. I think knowledge is super cool, but like at the end of the day, I want it to be something that has an impact. And I know that if I just do something that stays in my research lab and doesn't actually get disseminated, then A, it's wasted the money of whoever funded me, but B, it's not going to change things, right? And so ideally you start in that agenda by having that long-term dissemination goal, the culture change, as kind of the North Star for why you're deciding the agenda.
So we've got gun violence and injury and death in the context of people who may harm themselves through suicide. That's the target that we've been talking about.
Yeah.
Hers target is a bit larger.
Yeah.
You're the whole.
I'm the whole kit and caboodle. Yeah.
My question would sort of drive. My next question would drive to what are the other buckets you would go to next for developing a program like what Dr. Betz has developed? Yeah. I mean,
absolutely.
If you were to think about it as I have to go in order. And you don't have to necessarily, really, but if I do have to go in order, what kind of priority would you give, given your sense of where that literature is and where those priorities lie from doing this work?
So I'll say that there's active development. So Emmys is for suicide. Pat and I are both working on programs for community violence. He's up next in the next program. So there's ongoing work there. There is ongoing work with domestic violence, and I know Megan talked before. There's also other folks at University of Michigan and elsewhere who are doing ongoing work for domestic violence homicide. I think the mass shootings are the elephant in the room. They're the toughest. I think they're going to be the toughest to stop in this way. But if you do suicide, community violence, and domestic violence, that's going to get the vast majority. Then there's the accidental or unintentional injuries, right? And the case that was published in the New England Journal, and I forgot, was it Steve, was it you who showed the picture of the New England Journal of Peter and Shauna's article on the guy? Yeah, it was. That was an accidental injury, the case conference. Yeah, it was. His AR-15 went off by accident.
No, but you read through it further, and they determined it was indeed a suicide attempt.
Oh, really? I thought that they said that they thought it was suicide, and then they figured out it was accidental.
Initially,
Okay.
that's what happened, and then he finally came and talked about it. He was
Fair, at the very end, right before he died, yeah. But like, so the accidental injuries, that was a horrible one with the AR-15. Maybe it wasn't actually accidental, but we often see accidental injuries in the ED, but even more so with kids. I think that for a health system, that's a great area to work in. The trouble there is that when you talk about, I think that it becomes both easier to talk about because it's kids, and so they're a population that everyone cares about, but it's also tougher because you're telling parents what they need to do with their guns. So that becomes like a different issue. I don't know.
I would just add the one other specific area that we're moving into, not because it's biggest in either rates or burden, but because it feels a little like low-hanging fruit as well, is dementia. And sort of,
Right.
again, that's another very collaborative space to move into where people are asking for materials and information. Is a specific niche that I think can, again, is sort of that low-hanging fruit maybe.
Are there questions from those of you? Is there somebody standing up there?
Yeah.
Okay, I can.
Hi, I'm Julie Richards. I'm a researcher at Kaiser Permanente, Washington. Sorry, it's just a little weird to hear the feedback. So recently I was in a training with social workers in our system who work with, they do safety planning with patients who are identified as being suicidal. And what I learned from that training was that the social workers who were gun owners themselves had a lot easier time talking about firearms with their patients, and that just made me think about the work that you're doing, Emmy. And I was just wondering if you could talk a little bit more about how you got feedback from the patients and providers who contributed to your decision-making tool during that process, and like how that went.
Do you mean the feedback specific to the tool, or in general the provider training stuff we're doing?
Yeah, just I guess more generally, like the value of that process, how you went about it, just how you get feedback that's going to inform like the specific development of that tool and how that process went.
Fair. So I'll say that for the tool itself, we've sort of followed what I think is the typical process for decision aid development, which one-on-one interviews with stakeholders and sort of iterative versions of the tool where we were really drilling down to like specific words and feedback on imagery and trying to balance sometimes varying viewpoints. And we ended up going in a direction of very like neutral, like there's no sort of so there's some other people who have done really interesting work in this realm, more community facing, that sort of materials that are titles, things like People Who Love Guns Love You, and have sort of more of the sometimes like strong imagery around patriotism and things. It's sort of, we chose not to go that way because we were more sort of in a healthcare setting. I think I would share maybe just a couple of the anecdotes that I remember both from these interviews as well as from some other interviews, qualitative interviews we've done in the past that have been, I think, impactful to me. I remember we were talking with an emergency department tech who's a firearm owner who said he has heard physicians say to patients, well, why don't you just give your gun, just give it to your neighbor. And his point is that in Colorado, if you're a law-abiding gun owner, you know that's actually illegal. And that you have now that patient has just lost all trust in the provider. And I had never really thought about it before at that level of like, oh, actually providers probably should know a little bit about this kind of thing. And it's not that you need to know everything. I mean, I've had people say, well, is this like saying if you want to counsel people on cocaine use, you have to try cocaine? And like, no, but you need to learn how to not be offensive in the way you talk about things. And we learn that in medical school for other things. I remember learning how to take a history. Do you have sex with men, women, or both? And like, we all giggled a lot at the beginning. It felt weird, and then you get used to it. And I think some of this is the same, that we need to just have the basic information about the kinds of questions, how to ask, how to make sure that they're phrased in a way that is doesn't come off as offensive, because I think when you do that, like Chris, I've never had anybody get angry at me for doing it, because it comes from a place that seems genuine, I guess. I hope that partly answered your question. Yeah.
We can go to the next, that's fine.
Next question.
Yeah.
Hi, great to talk, both of you. I had some questions about your decision aid, because this is sort of something I'm struggling with. The first question seemed to be, how open are you into removing your gun from your household? And I wanted to get an idea of what is that scoring system, and at what point do you just say, okay, we're not going to talk about removing a gun from your household? Because I think particularly for adult suicide prevention, the evidence is kind of there that on-site storage is helpful, but not probably as clear as it is in the adolescent population. And so if you were to disseminate, implement this elsewhere, is there room for add-on motivational interviewing or some other layer of intervention that comes for that group that says, nope, not taking it out of my house, and this is what I want to stick with?
Yeah, I think that's a great question, and sort of where this falls. But the other thing that was interesting about this process is that this is a decision aid that's also trying to motivate behavior change, which is a little different than like if you're deciding between two cancer treatment options, right? And we had designed it so that it doesn't, you could certainly walk through it together and sort of layer in that motivational interviewing, I think. What's tough in lethal means counseling is that the general statement is, yes, get it out of the house, that is the safest thing. I think we were taking the sort of approach, though, that so what you didn't see was that the first 2 pages of it talk about how getting it out of the home is the safest thing to do, but then also wanting to acknowledge there are people that's a non-starter, and on that day, if that's where they're at, then maybe we sort of move on to it. In terms of a scoring system, it's just a slider. The whole point of those sliders is to force somebody to sort of think about it. Because of the confidentiality issues, it doesn't actually save that and then have spit out targeted feedback. We thought about that, but again, there's this concern about where are my answers being saved, and is this going into the Big Brother database? So we chose not to make it more complex for that specific reason. That could be great in other settings. And it might be that we find out in testing, people are like, why, confidentiality is fine, just make it fancier, and we might do that.
Yeah, in the future, somebody who's a 6 is different from somebody who's a 9. So
and that's part of the data collection, right? I think that's all of our goals as we create screening and counseling interventions, is to have the perfectly tailored and targeted intervention where we deliver it as, I think it was Dr. Richmond said earlier, that it's at the right time to the right person, but that it's also done in the way, it's the right voice for the right person, and it respects whatever 5-factor personality they are. And the permutations become endless. At some point, though, those permutations stop. So it's funny, in the texting program that I developed, we originally thought we were going to have 5 different sets of text messages for 5 different types of people, and it actually turned out that the differences between the different types of people and what they wanted were so minimal that it wasn't worth the extra cost or effort to write, 100 different messages to be delivered. So,
and at some point, too, again, it's don't let the
perfect
get in the way of the good. Yeah.
As emergency physicians, we believe strongly in that.
Thank you.
It's a good belief for many endeavors, I'll tell you.
Yes.
Next question.
Totally, George.
I appreciate both your presentations. They're excellent and really action-oriented, which I appreciate. The question I have is to both of you, but I think you were the one that started a little bit down this road around the sensitivity of invoking extreme protection order, which I guess you have in Colorado. Do you have it? You do not have it in
We
Colorado?
just passed it in Rhode Island.
You just passed it in Rhode Island.
And we don't have one.
So you don't have it. And I think the question is, I'd like you both to reflect a little bit on what potential opportunity you think that offers and how you might envision working that into your process.
Great question. So in most states, ERPOs can't be initiated by physicians. In most states, it has to be either law enforcement or loved ones who initiate it, which kind of clinicians could talk to law enforcement or could encourage family to report patients. But in most states, we feel that it's kind of like with domestic violence reporting, where if we're mandated reporters, it decreases disclosures to us. That said, I wish Garen were here. So Garen Wintemute from California, obviously, is in the midst of a study looking at the applications of the ERPOs in your state. Initially, there were very few reports, then there were more after they started doing some education. I think it's an area that's ripe for a lot of research and intervention. I think that we have to be very careful to not put healthcare providers in a spot that will reduce help seeking.
And I think that they're very promising and very really interesting approach that certainly won't fix everything, but I think they seem like, and the anecdotes that I'm hearing have the potential to prevent harm, especially in the context of mass shootings. I think as we are evaluating them, I hope we are also collecting anecdotes and evidence on things like misuse of them, because that's what I hear from my colleagues in the firearm world, that I think very valid concerns about whether people are going to be abusing them or not. And I think it would be great if eventually we can have sort of the data on what's actually happening and which states have model laws to then think about how we as healthcare providers can be aware of them to potentially work them in. And Maryland's law that just went into effect October 1st actually does allow clinician reporting, but I think there's some liability issues around like when people aren't protected. I think the last other thing I would just say is to recognize, at least in the context of suicide prevention, for most families, I think an ARPO is going to be like the last resort. I think it's great to have policy solutions that might help, but I think in this context, for example, like policy probably isn't the fix in the one-on-one relationship, right? Because most people don't want to go down the confiscation route. So a great option to have, but if we can get to the point where they're being used well and not having rights abused, for a lot of gun owners, I think it'll just be like there, but they don't have to worry about it, and that'd be great.
And I think it is state specific too. Like I know Chris, and I don't know if you talked a little, but I mean the number of ERPOs that have been filed in Vermont already, and this is a state of 500,000 people, to me is just staggering. I mean, he's had as many in 6 months, or the state reports that they've had as many in 6 months as California had in over a year. Right, so there is a state-specific aspect.
Next.
Hi, thank you both so much for your remarks and the work that you're doing. I'm Chris Brown. I'm the co-president of the Brady Campaign and Center to Prevent Gun Violence, and just wanted to make a comment and then ask a question. At Brady, about 2 years ago, we embarked on a process to do some research about how to talk to gun owners about the dangers of guns in the home. So we had some incredible support from one of the nation's leading ad agencies who went out and interviewed gun owners in 8 markets, talked to about 100 gun owners about the issue of guns in the home. And one of the pieces of feedback that they gave, which is probably obvious to you but hadn't been to me, is in general the term gun owner has become synonymous in our society, at least from this research, with being stupid. And that does not serve our interests as a gun violence prevention movement well at all. What we found is we need to come up with a term, a name, for the kinds of incidents that occur as a result of an improperly stored gun in the home. We wanted to come up with something like designated driver or secondhand smoke to get a variety of constituencies, physicians obviously being key, but so many, to actually talk about the issue of incidents with the gun in the home in a way that put the onus on the people with the guns in the home toward safe storage. So we came up with a term, family fire, hearkening back to friendly fire in the military, for the kinds of incidents that occur with a gun in the home, and we have an entire campaign to end family fire. It's focused at first on purpose because of the focus groups on kids. We tried and tested suicide kind of content associated with this, and it did not perform well, to use the marketing term, because it was very clear that was ill understood, the relationship between guns and suicide, with many of the people reacting to the content and saying, well, anyone intent on completing a suicide would do so. A gun doesn't play in. We have a lot more work to do. We went ahead with this campaign focusing on kids because the reality is safe storage saves lives across a variety of factors. And one of the things we consciously did on our website is focus on remote storage as well as storage in the home to try and address the issue at a later date. And I'm just wondering for you to provide feedback about how the discussions with safe storage about safe storage with your patients, how is it most effective? And how often are there conversations about what kind of storage to use and those kinds of details? Because I get the feeling sometimes that may be part of the reticence with raising the issue by clinicians, and just wondered your experience with that.
I mean, I think absolutely. I think I certainly never learned any of this in my residency. I mean, it's not, so I think emergency physicians who aren't familiar with firearms often have no idea what the storage options are and think that handing out cable locks, some think that handing out cable locks is like the solution because that's great, that's free, it's great. With the point being that for many people, a cable lock is not a desired storage solution because it requires disarming the weapon to use. I think it's going to vary by the setting. I mean, in my emergency department, we don't really see any kids, so it's all adults. And so what we're really seeing, the vast majority of the times that we can intervene, are people who are at risk of suicide. And again, we don't see the people who come in after the firearm injury, so it's hard sort of even educating our peers on that. And then youth who are involved in assaults or who are at risk of violence, that's more sort of referral to like a violence intervention program as opposed to like are you locking up your gun at night? Obviously, it's a different approach. And so I can only comment on the kinds of conversations that are happening in emergency departments with adults at suicide risk, which are really more in the realm of like what I was talking about, what will work for you for storage. And I think pediatric practices, for example, are probably going to be very different. I can't comment on that, but I don't know if you have.
So I would say two things. So yes, obviously, as emergency physicians, we don't have a ton of safe storage conversations. There was a good study published by Barkin et al. That was funded by NIH back before funding got cut, that looked at doing basically motivational counseling in pediatric practices that showed high acceptability and feasibility and self-reported changes in storage. Renad Betz, who again will be here tomorrow, will be talking, I know, about her program, which is around doing safe storage counseling for parents. So she'll certainly be able to answer your questions better, and she's awesome and has lots of thoughts. But I think that it gets back to, like Emmy's saying, there is this, this is one of the big research things for us to take on, right, as a group is, and I know also that there's some work going on at Michigan around this too, I should say, that this is one of the big things we need to take on, is saying what is the right language, what is the right way to have this conversation with a family that doesn't alienate them or make them shut off their brain the second I raise it.
And I would urge you to really think very carefully about the regional nature of some of these issues. I thought Dr. Betz's earlier slides, where she very carefully set a Colorado context for this conversation, which I recognized because I have a part-time residence in Colorado. I've lived in New Mexico, and my health system experience is Minnesota. Three very different environments where the subtleties of language and how things are positioned when you're doing consumer research or regular research or program design really make more of a difference than we would like to think. I suspect the people at Kaiser already know that because you have multiple regions in both California and Colorado, and that some of the programs, when they're deployed, really need to take that into account. So one, it's a caution about being cautious about drawing one conclusion for the whole country from a particular experience. And then secondly, it's an implementation sort of comment about tailoring the response to your audience very carefully. This is going to have to be the last question because I think we're about out of time.
Dr. Sadi.
So first a comment and then a question for Emmy. So Vermont has 600,000 inhabitants, thank you very much, not 500,000.
Oh, sorry.
And our ER PRIO went into effect this summer, and there have been 9 cases so far. And how it works out is a family will request a petition from against a family member, and then the police will come and disarm the person. So first is a family attestation, and then a police officer attestation, and then what happens afterwards, that person is usually brought for a mental health check. And so the question is, well, if we can get data on this cohort, then we can get a lot of information about what is that trajectory and the transition point to high risk. And my question for Emmy is, regarding your study and disarming people, is there an option for just taking or removing the firing mechanism? You know, in active duty military, soldiers who are identified to be at risk are just haven't had the bolt taken out, so they're not suffering the stigma of being identified as an at-risk person. Is there an option to remove the firing pin or other mechanism?
I'm so glad that you brought that up. So in we didn't really include that in this because, to be honest, for some family members, if they're not familiar with the firearms, it's a little complicated potentially for them to do. And I actually don't, this is a good research question, if an individual at risk of suicide who, let's say, concealed carries every day, would they disable their own gun so they could still carry it? I don't actually know. I think what you're referring to, which I think is a really interesting program that, at least in some military settings, service members who are identified at risk of suicide but have postings, let's say on base, where they're supposed to be carrying a weapon, are given their weapon but it's disabled so that nobody else can tell that it's disabled, so that they are not stigmatized, but and they can still be in their job, but they are at lower risk, which I think is a lovely solution. I will say in the dementia work we're doing, I think that's going to be a nice solution for many family members, so that especially if it's someone who's going to be very anxious and upset by seeing that their gun is missing, then can the family member, with help if they need it, can they disable the weapon so that they know, but the person with dementia isn't upset. It's a great point. We just didn't include it in the adult suicide version.
I think Emmy's answer is wonderful.
There's so much.
And I think both of your answers during this whole discussion have been wonderful, as well as the presentations. I must say that I'm grateful for what I've learned, and I know that this group here is also grateful for having had the information you've imparted. So please join me in thanking this group.
Thank you.
It's an honor to be here. Thank you.